Thanks to all of them. They've given us some specific things to think about, and now we will let you, by your questions, guide where we go deeper. And in this session, we'd particularly like to hear from the learners and from the health system representatives who are with us today, what their questions might be. So who wants to, Jordan?
Well, I don't fit into any of those categories, Carol, but I'll try. Yeah. Well,
Oh, you're always learning, right?
First of all, I just want to commend all three of the speakers. I think that's really a fabulous amount of work, and they're really very stimulating and productive. And I'm not sure that my question makes sense, but I'm going to try it anyway. As I understand each of these approaches, your unit of accountability is the individual. You're assessing skills that are involved in communication and interprofessional teamwork. And the assumption, I gather, is that if those skills are learned and adequately assessed appropriately, that when the team comes together, the team will perform its appropriate functions and lead to the better outcomes, namely better patient care. My question is whether or not that assumption is validated. That is, are there ways to assess the team performance in terms of how the team actually produces the outcomes that we're looking for? I think the assumption is obviously very reasonable, but I think in order to be rigorous, we need to figure out a way to validate that assumption.
Who wants to start? Brenda?
Thank you for the question. We started out with the context of telling the students about patient safety and why it was important to communicate. So it wasn't we just had a case, but we gave them the statistics about what a high-functioning team looks like, what it should look like, and what are some of the skills and behaviors. So I think even though the accountability was we all had students there, our goal was really to look at team behavior. And so we had to have faculty trained in reviewing the videotapes, knowing the case, and also team steps content on what is effective team communication, and there is evidence about teamwork. And so that's what they evaluated in the videotapes to say, did the team function well? Did they communicate well? Did they hand off appropriately? Did they share information? Now what we didn't do, because it was in a simulation lab, was did the patient's outcomes improve? So I think if that's what you're saying, no, we did not do that, but we did as much as we could in the simulation lab.
Yeah, I think you raise a real interesting challenge about teams and measurement collectively, and that is, am I focusing on the individual or am I focusing on the team, and how do I do that? And it really gets complicated when you talk about the skill of team leadership, because just from the get-go, there's an assumption that, in this case, right, the physician is the team leader. And when we trained our raters using the teapot, which you all have an example on in the trauma study, and we did use this in simulation, and we did look at patient outcomes, it's all captured in the study. What we agreed upon, if you think about the concept of teamwork, right, is that the whole is greater than the sum of the parts, that leadership could be evidenced by any team member. So if we take the idea, and I don't have the scale in front of me, the basic idea that we have a plan of care, the plan of care may change, and if we need to continuously update or render that, is that the responsibility of the team leader, or can any team member do it? So it's a behavior of the team versus behaviors of individuals. We trained our raters to focus on the behavior of the team. Okay, and that gets into, again, the rater training element of how I'm interpreting all these things that are on my scale. What's interesting is, because we referenced team steps, what we actually do is teach teamwork skills to individuals, because in the case of healthcare, the teams are always changing. So you're always bringing a different set of skills to each team situation or behaviors. But what would be nice is that everybody's coming in with a common frame of reference. So again, from a measurement perspective, we've tried, though it is hard, right, to think about if one person communicates well, two others don't, what's the aggregate score for this team? And you have to teach the raters, when you're looking at these behaviors, how you're interpreting it. But that's our goal. But it is a tricky thing, and that's the whole thing about studying teams, right? In their real environment, it's messy, right? And we're going to have to accept some messiness that's not going to meet the same type of standards that a written test is going to meet.
David, I think you've just made a point, too, for the importance of multiple observations, because some team members may not communicate, for example, in one scenario, but yet they might take the lead in the communication in another. George, and then Maddie.
So taking this messiness another step, first of all, I want to applaud you all, and I'm really excited and encouraged by how far this work is coming. Not only do we have this complexity of individual versus team, we have the complexity, which David kind of celebrated, and I agree I celebrate it too up to a point, of the number of metrics we have. We started with none and now we have many. Ultimately, we want to be able to understand this across institutions, across healthcare systems. I'd be interested in your observations, each of you working in the field, and particularly you, David, who are kind of looking at it maybe from a higher level. Is there a consensus emerging, and how will we arrive at kind of something that might look more like a common set of metrics that will have some comparability and transferability to different settings? And where are we in getting to that point?
I think that, and it's been a while, we did a review a little while ago of existing metrics, and there's been quite a few since. I think if you think about this kind of from what Dr. Nursini was talking about earlier in terms of measurement issues, and when we're thinking about measuring a construct like teamwork, I think we have a fairly good consensus about what the core knowledge, skills, and attitudes are that define team performance, and the behaviors at a generic level that represent those constructs. Now, where it breaks down and is going to be tricky is that what one team does in one in one domain is going to be somewhat different, how those generic behaviors are represented in those different domains. But I think you could create a mapping, if you will, to show commonality. Whether or not that's currently happening in the literature, because like everything, right, there is variability, I think, more in the team domain about what people call things, not what necessarily they're defining them as, right? So there are always going to be challenges with slightly different interpretations of the team domain itself, but I think that it's possible to achieve. Whether we're there or not, I'm not sure.
Anyone else? Jody?
Well, I was going to say that, we're testing the tool in one format, but the language in this instrument is such that a team could do a 360. They could assess each other around these interprofessional, professionalism behaviors and still get a sense of how well are we doing as a team in terms of how we all think we're communicating, where the design is the patient's at the center. The one that's even more interesting for us is that they actually have that happen at some point and then the patient to do the same assessment on that group. It'd be interesting to see how well they believe they're demonstrating behaviors and then what does a patient really think they're getting in part of their care. So that's next steps. We have to first get through one, and do we have a tool that we can work with? And then there's like 15 more questions. So how do you apply this in different ways if this in fact proves to be worthwhile?
There's maybe a nuance, too, on the first two questions together, and that is it's one thing to assess a team that is reasonably stable, like an OR team or a trauma team. But what happens in practice, of course, is teamness. The teams form and they dissolve, and they form and they dissolve. Do you have any thoughts about how you would measure that? Team ability, the ability to go into an institution and join a team and then 2 days later join another team.
Boy, that's messy. I think maybe focusing on applying some principles and adapting to local context. When you go, when we've looked at what we call high-functioning teams, and we ask them why they function well together as a team, they can't tell you why. So that's one of the problems that's hard to say. We want to find best practices so that we can mimic that and place our students there. But some of it is, like David said, if you're a team that works together all the time, it's your group, you've formed, you've done all of the group type skills, and now you work together as a team. But we do teach our students team skills because, as you know, they will be coming and going with different people. I think it's very difficult to do with uncertainty and complexity.
Mary, and then Scott, and then we'll go back in the room further.
I think David in his comments and the subsequent discussion distinguishing between teamwork skills and assessing teams is critical, because teamwork skills are something we need all the time in every situation where we're delivering care. I think teams, as a means to deliver care, are one way we deliver care. And we talk about rapid response teams, we talk about different kinds of teams, palliative care teams. Some of them are stable, relatively speaking. They work together over a period of time. They share a cohort of patients that they take care of. Others come and go, like you're describing, so it suggests that we need the teamwork skills as fundamental. But then the question of how you assess teams themselves when they exist is one where you have to have the right models to look at how high-functioning teams develop over time. So what is the process those people go through together? And there are some models for that. We did most of our work around the group development model. And we used a framework, a measurement framework called SimLog, where you can actually track where people position themselves through a self-report process in space, a three-dimensional space. And you can look at empirically how people move in that space over time and get to the point where there's shared leadership. And from the sociological literature, there are some frameworks for understanding what those emergent processes are and what the common problems are that groups of people need to come to terms with in order to achieve high functioning. And we've talked a lot about power and authority, and one of the common issues for any group to reach a high functioning state is resolving the power issue. So from my point of view, what we need context for is for those teams who are working together to figure out how they resolve some of these common issues in working together in the context where they're practicing. And that's going to look different. People working together are going to come up with different solutions to those common problems. And so I think there are models out there for how to assess teams. And I don't think we've taken advantage of those to date. I think we're still at the individual level, which is important, but we need to make the step up.
And I might say, and I hope I won't get in Patricia's bad graces by saying this, but if you know of good models, I think find some way to share them with staff while you're here for this meeting so that they could get included in the proceedings from this meeting, so that we can begin to build a list of models and references. So Scott?
Yeah, and I just really want to support Matty with her comments. And absolutely, I mean, she's absolutely right in terms of, again, trying to go in and think about sort of power and hierarchy and how to sort of get at that, which we're not really doing. The other thought I had, and to make an already messy situation a little bit messier, when do we call a team a team? Everyone calls themselves a team these days, and is just a group of clinicians working in the same space a team. They certainly seem to think so when you ask them, and certainly from my work, I've been studying ICU teams and also general internal medicine teams. I use that word advisedly for a number of years in 3 different countries. And again, what we're finding is there's a rhetoric of teamwork, absolutely. But when we're there for months observing interactions, and despite calling themselves a team, what we're finding is a lot of parallel play going on, and the more of a situation of this notion of not working. That individuals are coming together and tying these threads of activities very, very briefly, and then untying them, then tying them and untying them. And it's not a sort of teamwork approach that we're seeing here. And this is across ICU, where everyone thinks it's great kind of teamwork. We're seeing a more fragmented and more sort of ephemeral type of interprofessional interaction. And I was just wondering about trying to capture that and trying to assess that. Because again, a lot of the tools that you see as everyone has been saying, I mean, they assume a sort of generic, stable team, and they just don't really exist.
Yes, Pat?
First of all, I'm really excited to see the work done. We've been using team steps within the DoD for quite some time, and I think the point that we're at in terms of we've been able to see very successful models in OB and OR and ER and in the areas where we have not only more consistent players, but more consistent in terms of the practice and decision making. And so one of the things I think we really have to challenge is, do the models and do the assessments look different when we look at team across one team to another, which is a big area in patient safety, but then when we have the diverse teams like on large med-surg units, or what we're struggling with the DoD right now is with patient-centered medical home, how you look at that team virtually, so to speak, because you're not necessarily always seeing face-to-face the individuals that you're needing to work with. So I wanted to mention that, but then I wanted to have us think about two other initiatives that really play an important part, and we're starting to try to integrate within the DoD, and that's the high reliability organization work that's being done, because that really comes back to, do the team members not only know their role in the team, but do they know what to do from an evidence-based perspective in those different situations? And we find we see higher functioning teams where we have the high reliability organization work that's done to make sure we're all practicing on the same evidence base, as one point. The second one is the partnership for patients. And the partnership for patients really then talks about what is the role of the patient, family member, community on that team. And so frequently we see those as three separate initiatives, and we're really trying to bring those together instead of having them in parallel play, because they really inform each other beautifully, but we're not necessarily thinking inside the box or outside the box, I'm not sure, about how we might put those together. So I just wanted to say that this is something we've been doing team steps for quite a while in the DoD, and now we're trying to take it to that next step. And of course, we have some different power and hierarchy things to deal with, and actually I think there are lessons learned from what we've been able to do, even though we have a separate built-in hierarchy in addition to the traditional healthcare.
Anyone on the panel want to comment on that?
I see David shaking his head.
I think that some of these ongoing initiatives are interesting. You know, you have the partnership, you have the Team Steps national implementation, you have the cusp for CLABSI rollout, you have the little known, less maybe other people for the HAI national action plan. And what's interesting about those is they all should be dovetailing together and kind of talk, which I think at some level CMS through the partnership has done that. But I think what's most intriguing there is when you're trying to bed in the cost curve, let's say on a national level, is there's a lot of lessons learned to be captured in terms of how to do that. And now at this point, whether or not those have been gleaned from those activities to make available to transfer throughout healthcare, that's what I can't really speak to. But I think we know a lot, and we've been doing a lot, which has caused us to know a lot. But whether now all that we know is accessible to everybody is the next kind of challenge in that.
And I think it's just important that we don't continue to recreate the wheel. When there might be wheels out there, we can adapt.
We,
You ready for the question again? So you asked the groups that did well why they did well, and you said they couldn't tell you. My question was, did you ask the groups that did not do so well whether or not they could identify why they didn't?
no, so this was just asking folks that we know that have best practices. What are the strategies that you use? Why do you work well together? And they really couldn't come up with strategies, but they had done what we do. You know, we know how groups form and how people work together, and it has to do with over time, and they had a common goal. There were some things, but I guess my point was they couldn't say, no, these are the three things that we could do. So we could say, great, we'll go in and every site will prepare here's team strategies, here's how to understand systems. I was looking for things we could replicate. Some of it was communication, but no. So we haven't gone out and done that study yet. I thought you meant in the debrief with the students what went well, but that was a different question.
Malcolm, did you have your hand up next? Or you were just waving? No.
Speaker.
I wasn't just waving.
Good.
Someone had asked about comments from health systems about this whole business, and a few points I wanted to make. First of all, I think that's the right question, because we need to look at the outcomes on the AAA of all these intervening interventions. Looking just at the formation of teams, the effectiveness of teams, as important as that is, obviously. What we're really interested in is, are we improving health, both individual and population, and are we bending the cost curve so that bending, that reduction in the cost curve can be reinvested productively in other enterprises? I mean, that's what health systems are really interested in. So I think that is an outcome, which I haven't heard discussed, is really critical. And it comes back to what George had said earlier, that the two questions that were split in the previous session really ought to have been a single question. That is to look at just educational issues or learning issues as an outcome and not relate that directly to delivery system outcomes doesn't make any sense. So the VA, as you know, is undergoing a transformation in its primary care environment. That's a patient-centered medical home. And a lot of learning around team activities has been part of that rollout over the past now nearly 3 years. And without going into the specific educational interventions, it's pretty clear, becoming increasingly clear, what the health system delivery and the cost outcomes really are. And I don't have time to go into all of them, obviously, but some $800 million has been invested in this national transformation around primary care. After 2 years, we had recouped in discounted dollars about $600 million of that. And if you project the curves outward, in another year or two, they'll cross. So we'll actually begin to come into balance or maybe have some real savings that can then be reinvested. And I think it's important that that kind of perspective be taken, because if we sit here and deliberate about learning and education and don't figure out how we're going to fund that in the future, and that funding is going to have to come from our health delivery systems. There's not going to be any new money to do this. So bending that cost curve is sort of important. The last point I would make is some fascinating data is coming out now around this question of who was successful and who wasn't, and why were some of these more than 1,000 practice sites successful in improving health outcomes and improving utilization and saving money, and what other characteristics were there for the failed sites. And we've now just been able to categorize success and failure into quintiles, for example, across this whole system. And that will give us the ability to look at, why did this place work and that place not work? I don't have data to that. We don't have data to that effect. But I really wanted to emphasize this key issue of looking at what's real. And what's real is the healthcare system and what's going to fund education in the future. And if we spend all our time asking the question, what works in the team-based learning thing, as important as that is, we're going to miss the boat.
We have 2 quick questions here, and then we're going to wrap up for lunch. So, FF?
I just thank you very much for all the work you're doing. To make it even more messy, team effectiveness is not only about what happens during when they are all together. Another aspect of it, do they call on each other outside being together? Do they know when to call on each other? And who does the calling on each other? Is it still within the power structure that we are trying to get rid of? And how do we measure that what goes on outside the particular situation? So I don't know if you have answers, if you have looked at that.
So first of all, right, we kind of focus on a specific unit analysis, or I did, and let's face it, in any large organization, this is a multi-team system with a lot of complexity, right? And a lot of this gets into thinking about what you're trying to measure and why. And I'm kind of the mindset, if you can, from teamwork, right, if I can define it clearly, this gets back to some of the 7 principles that John put up here. Define it clearly, and you can observe it, you can more than likely measure it. At least in the trauma study, and that's the interesting thing, your team's going to change. So we tracked clinical outcomes over this scenario and looked at things like complication rate, mortality, and things of that nature. Those we didn't find an effect for, but we did track some internal process measures also that teamwork was related to these kind of important, what I would say, process area, time to intubation. Seems like if you need to breathe, I'm not clinical, right, that would be a good thing, but that's just me, right? Time to CT scan, time to surgery. So there is some efficiencies, and I think getting to your point, I think what's interesting about medical homes, ACOs, different even bundle payments, things of that nature, there's a quality element to it. And if you're managing a population of patients, or even small or a single patient that has chronic conditions, there's going to be a team-based element to that. And dissecting that to figure out how to make sure that Mrs. Jones or whoever comes back because she has type 2 diabetes for this is going to have a team element to it, which will be important for whatever metrics are being used to judge you on your reimbursements for quality, as I understand it. So I do think there is a way to tie this in. There's been more in the literature about linking these things to actual outcomes, but it's still trying to keep up with the innovations in care at some level, though it's gained a lot of traction in 10 years.
Eric, do you have one last question? Okay. All right, so in closing, this morning, John Noacini said that institutions were not very good at sharing assessments, which is absolutely true, and in today's economic climate, we can't afford that anymore. So I just draw your attention behind tab 6 in the book to one effort to try to bridge this gap. It's a project that's called DREAM, and don't ask me what the acronym stands for, but this is an effort that actually came to us from faculty at the Georgia Health Sciences University, and the commitment is to do critical analyses of assessments that are in the public domain that might be relevant to other healthcare institutions. So we have a commitment to publish 100 of these by the end of the year. Each critical analysis includes a description of the assessment instrument, educational objectives, relevant competencies, the audience, and then relationship to instructional methods. And I took a quick look yesterday, and of the 40 that are already published, 12 of them have, is that right? 6 of them have relevance, no, 12, have relevance to interprofessional learning, relevant to more than one profession, and of the 60 that will be published before year end, another 28 are relevant. So hope there'll be something useful, and we would encourage people who have assessments, especially that relate to interprofessional learning and team skills, to offer them up to this process. So any comments before we go to lunch, Darla? No, I wouldn't dare. And thanks to the panel. One more round.
Yes, so now it's time for lunch. Patricia, I'm going to turn to you for any details. I think people just get lunch and come back in here.
Yeah, go ahead and get lunch. Be back in here by 1:15 in order to receive directions for the breakout groups. So 1:15. And lunch is right outside this door.
Great, thank you.